with my partner, Siu Tong. And we hope you're having a great Saturday night. And we thank you for very much for joining us for the QIUP Virtual Public Health Campaign.
Okay, today we are thrilled to welcome the Chief Pharmacist of Ipoh O Hospital Raja Pemansuri Bainon, Dr. Doris George, to our campaign. Dr. Doris will be enlightening us on the art of managing medicine and how it can help with hypertension.
Thank you very much for joining us, Dr. Doris, and good evening to you.
Hi. Good evening.
So we can start our talk today.
Okay. I'll straightaway share the slide, okay? Okay, a very good evening to everyone. So I'll be talking about the art of medicine management. So basically, we're going to talk very detailed about medicine and how we're going to manage patients, and also at the end of it, we're going to see various patients on different kinds of therapies, condition, and how we're going to tailor our medicine to these patients. So before we can actually talk about the medicine, we need to talk about blood pressure categorization. Okay, how we would categorize a patient, whether the patient has hypertension or not. So actually, if you see the blood pressure categorization, we have 4 categories, which is normal or elevated, which is considered a non-hypertensive patient. And in the hypertension group, we can categorize them into stage 1 or stage 2. So as you all know, the normal blood pressure is definitely the systolic blood pressure should be less than 120 millimeter mercury, and the diastolic blood pressure should be less than 80. If a patient is considered elevated, so this is only you have elevation of not more than 10 millimeter mercury, both the systolic and diastolic in systolic blood pressure, and the diastolic is still the same, which is less than 80 millimeter mercury. So if a patient has higher than that, so then you will categorize them as hypertension. Stage 1 will be 100 when the systolic blood pressure is 130 to 139, or the diastolic blood pressure is 80 to 90. Similarly, if the stage 2, then the systolic blood pressure will be more than or equal to 140 millimeter mercury, or higher or equal to 90 millimole diastolic blood pressure. Okay. So the prevalence of hypertension in Malaysia is increased from 34.6% in 2006 to 35.3% in 2015. So actually, if you see the numbers, they didn't increase much, but the prevalence is similar. So we can actually say that 1 in 3 adult Malaysians have hypertension. That is considered quite serious. And if you later in the, I think tomorrow's section, so the doctor will be talking to you about hypertension in detail, how to diagnose and what are the signs and symptoms. But the scary part about this is that hypertension can be asymptomatic, and many patients or adults, even in Malaysia, are not aware that they are hypertensive. Okay. So so now we are talking about medicine. So I'm just going to say, why is it so important to control your blood pressure? Okay, so why do you need to take medicine to control your blood pressure? So what will happen if you don't take control your blood pressure? Okay, so blood pressure has 3 direct effects on your health, which is it can increase if you control your blood pressure, you can actually reduce the stroke risk by 30 to 40%, and heart attack, or we call it a myocardial infarction, by 20 to 25%. And it can, if you control your blood pressure, you can also reduce heart failure by more than 50%. So controlling blood pressure is really important. So because you can see the risk of stroke, heart attack, and heart failure can significantly reduce with the control of blood pressure. This is another slide which shows that a major cardiovascular event is definitely lower among patients with lower blood pressure compared to patients who have high blood pressure. And it also reduces the mortality. So if you see a patient having high blood pressure, the mortality rate would be higher compared to a patient with a controlled blood pressure. Okay, so this is very significant. If you see all those boxes, square boxes, are actually on the right, on your side, which favors the low blood pressure. This is a meta-analysis recently in JAMA 2017. So it shows that controlling the blood pressure actually reduces major cardiovascular diseases as well as mortality. So now we're going to go to medication, how medication helps in controlling blood pressure, okay, and what kind of medications that are used for blood pressure control. So actually, before you even think of starting medications, you need to identify the hypertension that the patient have is actually a primary hypertension or whether it's a secondary hypertension. So secondary hypertension meaning that there are some causes that cause the patient to have elevated or high blood pressure, or causing the patient to have become hypertensive. So causes of secondary hypertension can be divided into two main classes, which is caused by medicine or caused by medical condition. Okay, if you see the medical condition, some of the medical conditions that can cause hypertension is obstructive sleep disorder, primary aldosteronism, renal parenchymal disease, and renal vascular disease. Okay, these are some of the medical conditions that can raise the blood pressure and cause one to become hypertensive. So medications, like now we are talking about medicine, besides medication being able to control your blood pressure, it can also cause you to have be hypertensive. So some of the medicines that can increase blood pressure are sodium containing antacid. Usually, if antacid is something that you use to prevent gastric effect, so if you contain sodium, you may have a tendency to be hypertensive. Caffeine, overuse of caffeine can also contribute to hypertension. Nicotine, okay, is smoking. Alcohol, overabuse of alcohol can also cause hypertension. NSAIDs are also known as painkillers. Okay, long-term use of painkillers can contribute to hypertension. Oral contraceptive, this is one of the major culprits in women, where young women may have hypertension, and before you can actually put them on medicine, you must rule out that they're not taking any medicine such as oral contraceptive that could have contributed to them being hypertensive. So what you should do is maybe put this patient off this medication and see whether the blood pressure reduces. And symptomimetics, these are drugs that you use to control your nose blocks and stuff. Overuse it or long-term chronic use of this can also cause hypertension. Illicit drugs such as amphetamines and all those drugs, recreational drugs, can also cause increased blood pressure. Neuropsychiatric agents, and last but not least, the erythropoietin stimulating agent, which is used in chronic kidney disease patient to increase their hemoglobin. So these are all drugs that can contribute to hypertension. So if a patient has elevated blood pressure, that means if a patient has got a systolic blood pressure which is 120 to 129 and diastolic pressure less than 80 millimeter mercury, what do we do? Do we straight away give them medicine? Actually, the answer is you have to see whether the patient has clinical AS, this is atherosclerotic coronary vascular disease, or an estimated of 10-year risk of less than 10%. Okay. So if a patient has there is no clinical AS severity or the estimated risk is less than 10%, so you just need you just give them non-drug. You mean you don't give them medicine to treat the high blood pressure. Okay, you just need to treat them with non-drug. Okay, so and then you need to reassess them in 3 to 6 months to see whether the blood pressure is reduced. So if despite all your treatment and non-drug thing, if the patient does not the blood pressure still does not reduce, that maybe you might consider putting him the patient on some medicine. Okay, so now you might be asking me, what is a non-drug therapy? So probably I think you may have listened to some of these things, so I'm just going to give you briefly, which is weight reduction. So if a patient is very heavy or obese, so the first thing that you should talk to them about is weight reduction, because weight reduction can actually reduce the systolic blood pressure approximately by 5 to 20 millimeter mercury per 10 kg weight loss. So every 10 kg they can actually reduce the systolic blood pressure by 20. Okay, the DASH diet. So probably I think you have heard about the dietitian talking about the diets. So that can approximately reduce the systolic blood pressure to 8 to 14. And if you reduce salt intake in your diet, that will reduce your systolic blood pressure by around 2 to 8. Physical activities. Physical activities like running 3 times a week and stuff like that. You can also reduce systolic blood pressure, estimated about 4 to 9 millimeter mercury. And moderate alcohol consumption. If you decide to reduce your alcohol consumption, you can reduce your systolic blood pressure by 2 to 4. So if you see, basically the average systolic blood pressure that you can reduce by all this non-drug is around 10 millimole millimeter mercury. So that's why patients with elevated blood pressure, because elevated blood pressure is about elevated of systolic blood pressure more than 10, you see. So that's why this group of patients will be benefit from non-drug therapy. So if a patient is categorized as stage 1 hypertension, which is systolic blood pressure ranging from 130 to 139 and diastolic blood pressure 80 to 89. So the first thing that you need to know is you need to assess the patient's whether the patient has clinical atherosclerotic cardiovascular disease or estimated 10-year risk of more than 10. If the patient does not have, then you just start them with non-drug, and then you reassess them within 3 to 6 months. Okay, but if they have a clinical atherosclerotic cardiovascular disease or an estimated 10-year risk of more than 10%, then you need to put the patient on a non-drug. You need to advise them on a non-drug therapy, as well as put them on a drug medicine to reduce the blood pressure. And in this group of patients, you need to reassess them within 1 month. Okay, and after 1 month, you need to check whether the blood pressure is within the target goal. And then, if it is yes, then you see them within 3 to 6 months. If it is not, then you need to optimize adherence. First, you need to check that the patient is adherent to his medication. That means, is he taking his medication as prescribed? And then you need, if he is taking his medication as prescribed, then you may consider optimizing his medications. Later, we probably will be talking to you. I can explain to you how we optimize this antihypertensive. So, what is the target blood pressure for patients like this? You consider reducing their blood pressure, because just now we talked about target blood pressure, right? So what is the target? Is actually less than 130 to 80 millimeter mercury. Okay, so all the patients more than 65 years community acquired, you need to reduce the systolic blood pressure by actually just consider their systolic blood pressure alone, because the diastolic blood pressure may not be so easy to be controlled. Okay, stage 2 hypertension is when a person's BP is more than 140 90 millimeter mercury. So in this group of patients, what do we do? So we will start them with a non-drug and drug therapy. Okay, and then you need to reassess them in 1 month. Okay, these are high-risk patients, so we need to reassess them in 1 month. And if BP at goal, then you need to reassess them in 3 to 6 months. Okay, but if their BP is not in target goal, then you need to optimize adherence. You need to talk to them about adherence and optimizing therapy. But in this group of patients, stage 2 hypertension, you will need to start the patient on 2 first-line agents of different classes. So a patient with stage 1, you start them with 1 first-line drug. But a patient on stage 2 hypertension, you will actually have to initiate them with 2 therapies at the point of diagnosis. Okay, so this is the kind of saying that you initiate drug therapy with 2 average, 2 when the average BP is more than 20, systolic blood pressure is more than 20, or diastolic blood pressure is more than 10 above the target. So you need to consider putting the patient on 2 drugs. Okay, so what are the medications in controlling? So I told you when we can start them. We need to start them after we rule out if the patient doesn't have secondary hypertension. Then how do we, there's 2 options. We can start them on a non-drug therapy, or we can start them on drugs. And when should we start them on a combination, and when we should just start them on single. So stage 1, you can start them on single. Stage 2, you will probably have to put them on a combination drug. Okay, so what kind of medications? Now we go to the detail about what types of medications do we have out there. Okay, so basically we can categorize them into A, B, C, D. So drugs that are in the group A are angiotensin converting enzyme inhibitors, which is ACE inhibitors, angiotensin receptor blockers, which are ARBs, and alpha-1 blockers. Okay, these are all the groups of drugs in A. In B, you have beta blockers. It's the only drug in this group. C, you have calcium channel blockers and centrally acting antihypertensive. And last but not least, D is diuretics, and you have direct renin inhibitors and direct vasodilators. Okay, so medication in controlling blood pressure, or called antihypertensive, can be divided into 2 groups. Okay, they are called the primary agent or the first line agent. These are drugs that are put in as first line. That means in stage 1 or stage 2, you will actually need to start a drug from this category. Okay, it can be A, angiotensin converting enzyme inhibitors, or an ARB, or you can put them on a calcium channel blocker, or you can put them in a diuretics, but provided the diuretic is a thiazide-like diuretic. Okay, these are primary agents. So wherever you go, if your patient is started a medicine, these drugs are the first line. They need to be on these drugs. Okay, but which drug should be the patient be on? Should he be on an angiotensin B, or should he be on a calcium channel blocker, or should he be on a diuretic? Is something that we might we be able to talk, not in such great detail, but I will explain to you later. So this is another group of drugs. I told you medication can be categorized into 2, which is the primary and secondary agents. These are secondary agents: alpha-1 blockers, beta blockers, centrally acting agents, non-thiazide diuretics, direct renin inhibitors, and direct vasodilators. These are secondary agents. Okay, these are drugs that you put on as the 3rd or the 4th drug. Okay, so they are not the primary drugs. They are not the ones you start a patient on when the patient comes in with blood pressure, elevated hypertension. Okay. Okay, maybe we will just go briefly into all the drugs that we were just talked about just now. So starting with the first line agents, with this angiotensin converting enzyme. So these are some of the drugs. In your left side, you can see perindopril, ramipril, enalapril, and captopril. So these are drugs that are available in Malaysia, and there might be other drugs that are also available. These are the most commonly available medicine in Malaysia. So how they work is they prevent the conversion of angiotensin 1 to 2. So angiotensin 2 is a potent vasoconstrictor. So it actually is a competitive inhibitor, and therefore it lowers the concentration of angiotensin 2. It also works by increasing plasmin-renin activity and also reduces the aldosterone secretion. So this is how it reduces the blood pressure. This drug is the first line and usually very, very useful in most patients. So angiotensin converting enzyme, the indication is it is mostly effective or it's a must drug if you have albuminuria. Okay, that means you have albumin in your urea. So this is a drug that you need to put it on because it can just reduce the progression of albuminuria. And then if your patient has heart failure, this drug can also be the first choice. And or cardiovascular diseases, NMI, myocardial infection of a heart attack, or a recurrent stroke. The patient has a stroke and then he got a stroke again. So this probably is a choice of drug. Okay. And what is it contraindicated? The main contraindication for this drug is bilateral renal arteriostenosis. So that means if you have got a renal arteriostenosis bilaterally, so this is definitely a no drug. Pregnancy and angioedema. Okay, angioedema is the swelling of eyes and all that. For inhibitors, the most common site of edema is the tongue and the lips. Okay, so adverse drug reaction is it can increase the serum creatinine approximately 30% from the baseline, but anything more than that, you need to be worried and you may need to stop this drug. So it can also cause hyperkalemia, angioedema. So yeah, if you have angioedema, if the patient has this reaction, you should not be, you should not be putting the patient on it. It can be fatal. So although it's rare, but it can be fatal, and it also causes dry cough because of this mechanism of action. Okay. So the next class drug is angiotensin receptor blocker. So the groups of drugs is on your left, like losartan, irbesartan, telmisartan, and valsartan. So these are first-line agents similar to ACE inhibitors. They're selective competitive angiotensin 2 receptor type 1 antagonists. Okay, it reduces the end organ response to angiotensin 2. Okay, so this indication is similar to ACE inhibitor. Okay, it is effective as all those things that ACE inhibitors can do. It's also the contraindication is also similar to ACE inhibitors: bilateral renal stenosis, pregnancy, and also angioedema. Similarly, the adverse reaction is also the same. So increased serum creatinine, hyperkalemia, and angioedema. Okay, so if a patient has angioedema, so probably you may not, even ARB may not be the choice. But the only difference between ACE inhibitors and ARB that is in terms of the adverse effect. You see the cough is missing, the dry cough. The dry cough is very prevalent with ACE inhibitors, but it is not so with angiotensin receptor blockers. Okay. So the other drug that we are going to talk about is also a first-line drug, which is calcium channel blockers. So okay, calcium channel blockers, they are divided into two groups, as some of you might know. They are called dihydropyridine, which is this group of drugs are amlodipine, felodipine, nicardipine. Okay, these are the group of drugs. And the non-dihydropyridine, the two most famous drugs in this group is diltiazem and verapamil. Okay, so dihydropyridine, they relax the smooth muscles in the artery walls and decreases the total peripheral resistance. Okay, that's how it does. It just vasodilate the arteries. The non-dihydropyridine are potent coronary artery vasodilators. So they increase the blood flow and reduces peripheral resistance. And they also decrease heart rate by depressing atrioventricular AV node conduction and reduces. So this is the difference between the non-hydropyridine and hydropyridine. It actually can decrease the heart rate. Okay. sorry for my slide there. First line, okay, the indication for CCBs are, yeah, the first line for dihydropyridine, it improves angina symptoms, okay, and CV mobility and mortality benefits. This is the indication. And it is also can be used in patients with heart failure and AF or stable angina. Okay. As for the contraindication, sorry, my things did not appear as it's supposed to. So the contraindication is heart block for non-dihydropyridine calcium channel blockers, and also sick sinus syndrome. Okay. So the adverse drug reaction for dihydropyridine CCB are peripheral edema. Okay, you can get your ankle swelling. Orthostasis, that means when you get up from a sitting position or from a lying position, you will get like, low blood pressure. Reflex tachycardia. Okay, this is another thing that what happens is the body's mechanism, and you will tend to have palpitation. Okay, when you put on this drug. So sometimes it goes away, but over time. But if it is a problem, then you probably have to put the patient out of it. Okay, for peripheral edema, usually what we do is you combine this drug with an ACE inhibitor, and you can actually alleviate this side effect. Okay, so that's why it's preferred to be given together with an ACE inhibitor. So, like non-hydropyridine CCBs, the adverse effect is heart block, bradycardia, and also constipation. These are some of the problems with this group of drugs. And if you can see, their side effects are so totally different, and it's a bit, they are, they work in totally different pathways. Okay, so then here we go to the other first line drug, which is thiazide or thiazide type diuretics. So we have two types. If you see diuretics, they have the thiazide diuretics, they have the loop diuretics, and the potassium sparing diuretics, and aldosterone antagonists. Okay, so I've also put all the drugs below each of the diuretics for you to look at it. So this drug is thiazide or thiazide type diuretic. We're just talking about them. They are the first line agent, and they can be used as monotherapy or combined therapy. In majority of cases, they usually combine, and they also come in a lot of preparation whereby they are combined with an ACE inhibitor, or they can combine with a lot of other drugs. So usually they are combined. They come in a combined formulation. Okay, easy for treatment. So they act as on the kidney to reduce the sodium reabsorption in the distal convoluted tubes. Okay, they impair the sodium transport in the distal convoluted tube. Natriuresis and concomitant water loss are induced. Okay, that's how they work to reduce the blood pressure. Okay, so this is the loop diuretics, which is also the thiazide type diuretics. Also can be used as monotherapy or combined therapy. And how they work is they reversibly bind to the natrium, potassium, and chloride co-transport on the luminal side of the ascending loop of Henle, and they inhibit the active reabsorption of these ions. Okay. So the indication for these drugs, they enhance the efficacy of multi-drug regime. Okay. Cotalidone is preferred, and it is shown to have reduced coronary vascular outcome. Okay. Loop diuretics are patients with CKD or heart failure. So because patients with CKD, thiazide diuretics are contraindicated. So these groups will benefit from a loop diuretics. Contraindication is anuria, okay, because if you don't have urine, you probably will not be benefiting from this drug. So adverse drug reaction is electrolyte imbalances. Okay, you can have hypokalemia, hyponatremia, hypomagnesemia, and hyperuricemia. Okay. So now we're coming up to secondary medication in controlling blood pressures. Earlier we talked about all the primary, so there are ACE inhibitors, ARBs, CCBs, and also diuretics, which are the thiazide-like diuretics. Okay, for thiazide diuretics. So here we have the other group of diuretics, which is the potassium sparing diuretics. They can be the, like you said, is the secondary drugs, and also the aldosterone antagonists. Okay, they block the epithelium sodium channels on the lumen side of the collecting tubules, the potassium sparing diuretics, and they inhibit the sodium entry into the sodium channel. Okay, so the indication for is they can be combined with the thiazide diuretics for potassium balance. Okay, so if the patient is hypokalemia, so you can actually give together with the potassium sparing diuretic so that you can balance up the potassium. So aldosterone antagonists are usually used for resistant refractory hypertension. Okay, and patients with heart failure. These are the group of patients that will benefit from this class of diuretics. Okay, and the contraindication is similar to the other looked at thiazide diuretics, which is anuria. Okay, if you don't have urine, these drugs don't work. So hyperkalemia, because this can also become worsen your potassium level in your body. And the other one is the renal impairment. Okay, if you have renal impairment, so these drugs may not be suitable. So adverse drug reactions are hyperkalemia. Okay, they can cause elevated potassium. They can cause gynecomastia and mastodenia. Okay, this is like the swelling of the breast and painful breast. Usually is seen in spironolactone. Okay, this is specifically for spironolactone. Okay, aldosterone antagonists. Okay, they how they work is they inhibit the effects of the aldosterone by competing for the intracellular aldosterone receptors in the cortical collecting duct. Okay, they decrease sodium and water reabsorption and decrease potassium secretion. This is how they work to reduce the blood pressure. So we go to the other secondary hypertension, which is beta blockers. So interestingly, beta blockers, they can be categorized into 4 ways, which we can call them as cardioselective. They are also categorized as combined alpha and beta receptor blockers, cardioselective and vasodilator beta blockers, and non-cardioselective beta blockers. So cardioselective beta blockers, the 3 that I listed here is bisoprolol, metoprolol, and atenolol. The beta blocker with both receptor blockers, which is alpha and beta, is carvedilol and labetalol. Cardioselective and vasodilatory component is nebivolol, and non-cardioselective that I've listed here is propranolol. These are some of the common drugs, the beta blockers that are seen in Malaysia. So how they work is they selectively, which is beta 1 only, and non-selective, they block both the beta 1 and beta 2 receptors, resulting in an inotropic and chronotropic effect. Okay, so inotropic effect is, of course, they actually reduce the force of the contraction. Okay, therefore, they reduce the beat. Okay, and the other one is chronotropic, the rate and the rhythm. So this, they actually reduce the rate and rhythm. Okay, just earlier it was the force. Sorry. So beta blockers, the indication, usually you use it for a patient with, as a first line in patients with have heart failure. So if the patient comes with a blood pressure, elevated hypertensive, and also has heart failure, then this drug has to be put on. And another time that you need to put the drug as a first line will be when the patient has comes in together with the MI. Otherwise, you will never use this drug as a first line. You will just use it as a third or fourth line as an add-on when the patient is not responding to more than 2 or 3 drugs of the primary drugs. Okay. Contraindication is sinoatrial or AV node dysfunction, because this can further worsen the bradycardia and so forth. Decompensated heart failure, if the patient is coming in with an acute heart failure with symptoms of heart failure, so these drugs should not be initiated. And severe bronchospastic diseases such as asthma, COPD, so these drugs should not be put in, because they are, some of the non-selective drugs can actually cause bronchospasm because of the beta suppression. So adverse drug reaction, the most common ones are bradycardia because they actually suppress the AV node, heart block, sexual dysfunction. Okay, this can be some of the counseling points that we need to talk to patients. Sometimes patients do not adhere to this drug because of this side effect. Fatigue, you also need to tell them that initially when they are put on this drug, they will experience this, but over time, the body will be able to tolerate, or they might be able to cope with this fatigue, and they will have exercise intolerance, especially if an athlete is put on a beta blocker. You may feel that his tolerance to exercise is lower. So these are some things that you need to talk to the patient to continue to take the drug, and probably these symptoms will be able to be managed well. So next we come to this central alpha-1 agonist, which is we have clonidine, methyl dopa, and guanfacine. So these drugs, they stimulate the alpha-1 receptors in the brain, and they decrease the symptomatic outflow, cardiac output, and also the peripheral resistance. Okay, by stimulating all these things, all alpha-1 receptors. So the indication for this drug is they use it for when there is resistant hypertension. Resistant hypertension is when there is more than 2 or 3 drugs. You put the patient on a few drugs and they are still hypertensive. So that's when you add these drugs. You can also use this drug for hypertension emergency. That means you have a patient coming in with elevated blood pressure, which is more than 200 or 190, above that. So you may need to use this drug. And also in pregnancy, this methyl dopa is very suitable for treating blood pressure in pregnant patients. So contraindication is you should avoid in heart failure patients because it can worsen heart failure. So you should never use them in heart failure patients. So the adverse drug reaction is they can cause dizziness, drowsiness, tremor, AV block, and bradycardia is commonly seen with clonidine. These are some of the side effects of this drug. So the other drug will be direct renin inhibitor. I think this is the last drug, which is also called aliskiren. Okay, this is a direct renin inhibitor. It decreases the plasma renin activity and inhibits the conversion of angiotensinogen to angiotensin 1. Okay, so it's called a direct renin inhibitor. It's indicated it is never to be used as a monotherapy. Okay, like it is a secondary drug, so you should never use them as monotherapy. It's not going to be effective. So it's got a whole list of contraindications. So this is a drug that you need to think about. So it is contraindicated in pregnancy. It is contraindicated in patients with diabetes in combination with ACE inhibitors and ARBs. It is contraindicated when it's combined with cyclosporine and itraconazole, and used with ACE inhibitors or ARB when the creatinine clearance is less than 60 mils per minute. So you've got a whole lot of contraindication for this drug. And the adverse drug reaction is angioedema, hyperkalemia with ACE inhibitors. Okay, so this is some of the adverse drug reactions. So the last one is alpha-1 blockers, which is prazosin, doxazosin, and prazosin. Okay, so they are selective alpha-1 antagonists and cause vasodilation. So by causing this, they can actually decrease total peripheral resistance and venous return. So they are indicated especially in male patients who are hypertensive with benign prostatic hyperplasia. Okay, so they are very suited for this group of patients, and they are also suited as a fourth or fifth agent in the management of hypertension. So contraindication for this drug that is very prominent, and the adverse drug reaction is dizziness, and it can cause orthostatic hypotension. Sorry. So this is the last one, the direct vasodilators, which there are 2 groups of drugs, which is hydralazine and minoxidil. They are direct smooth muscle relaxation and access primarily in arteries and arterioles. So they are indicated for resistant hypertension. Okay, and like you say, it's useful as a fourth or fifth agent for hypertension. There's no contraindication, and the adverse drug reaction is it can cause tachycardia. Okay, if they have tachycardia, you can use it with beta blocker. Hydralazine, it can cause drug-induced lupus-like syndrome. Okay, headache is prominent with minoxidil. Okay, retention use with loop diuretics. Okay, if you see fluid retention, then you can use loop diuretics, and they can cause pericardial effusion and cause hirsutism. Okay, facial growth, hair, and what. So I'm just going to briefly just explain to you, what do you do with patients coming in with a few conditions. So if the patient comes in with ischemic heart disease, let me see, got a previous MI or a non-STEMI, so the patient should be guided. It is called guideline directed medication therapy. So in this group of patients, beta blocker should be on board. ACE inhibitors and ARB should be a first choice. Although beta blocker is not a primary hypertension drug, in this group of drugs, patients, they should be on board. Okay. If the patient is a diabetic patient, so what do you do with the first line drug? You should give them the first line drug, which is diuretic, ACE inhibitors, CCB. Okay. In the presence of albuminuria, ACE inhibitors and ARB is the first choice. Okay. So if a patient comes in with a chronic kidney disease, so if it is a more stage 3 and higher, or stage 1 and 2 with albuminuria, is ACE inhibitors and ARBs. Okay. If a patient comes in with cerebral vascular disease, so as a primary prevention, thiazide diuretic should be on board, ACE inhibitors or ARB, or combination of thiazide diuretics plus ACE inhibitors. So this is the drug of choice, okay, based on the patient. Last but not least, if a patient comes in with heart failure, so you need to put them, it's called also guideline directed medication. So ACE inhibitor should be on board or ARB. Beta blocker should be on board, diuretics, aldosterone antagonists. And the choice of beta blocker in this group of patients should be metoprolol succinate, carvedilol, or bisoprolol. These are the 3 groups of beta blocker that be a good choice for patients with coming in with hypertensive and heart failure. Okay, so how long to take antihypertensive? These are some of the questions that your patients will always ask, so you know it is lifelong. They need, once they start, they will probably be taking the medicine lifelong. So adherence to medicine is the greatest problem to hypertension. Most patients don't feel any symptoms. You have high blood pressure, but you don't have symptoms. So this is the most common problems with patients. So adherence with pharmacotherapy for hypertension in 1 year after initiation is typically reported as less than 50%. So that means not even half of the patients are taking a medication. So therefore, the role of pharmacists is very important, teaching them of how to, why it is important to take the medicine, why even though they don't have symptoms, they still have to take the medicine. So these are some of the educating public is really, really, really important, so that they can better manage and not come in with a stroke or an MI, or even end up having heart failure. So ways to increase adherence, because some of them are young patients, or maybe they only have hypertension if they don't have anything else, they've never taken any drug before. So probably you can tell them to set an alarm. This can be done in the phone or a real alarm clock. Okay, they can use pill boxes, and I advise them to take pill boxes that they can actually carry around with them wherever they go, even for holidays. Now they have technologies where you can actually detect your blood pressure that in through your smartphones. Okay, you can also have watches that are connected to your phones, and then they can actually detect the high blood pressure, and they can actually send an alarm to your phones. And these are technologies which you can use to increase your adherence to the medication therapy. Okay, with that, I would like to end my presentation. If you have any questions, I will try to help answer it as best as I could.
Thank you, Dr. Doris, for the enlightening session. Now we will have questions from the floor. Dear viewers, please ask your question in the comment section and we'll highlight them to Dr. Doris.
Okay, so while we're waiting for the first question, I would like to ask a personal question of mine to Dr. Doris. For people who is suspected of hypertension, what would be your best recommendation before they see a doctor? What do you suggest they would do?
You mean what would you suggest a patient who's already diagnosed as hypertension or not diagnosed as hypertension?
Or when they diagnose as hypertension, when they diagnose.
I think they should definitely see the doctor and they need to check the algorithm that I put. So if their blood pressure is really high, and they probably need to, of course, non-drug therapy is a must for or everybody, and then they need to get the advice from the doctor to see whether they need to put them on medicine or not.
So for our second question,
Should we take the medicine for lifetime? Forever?
Yes, we should take the medicine for lifelong. Once you are diagnosed as having hypertension, you cannot say that your blood pressure will actually reduce and you can stop taking it. No, it's not. It's like lifetime. So this is the most difficult thing for a patient to accept.
okay, so for our third question, could you let us know how is the pre-eclampsia managed?
Okay, some of the drugs that are used for preeclampsia is such as labetalol, methyl-dopa. These are the drugs that are commonly put for patients with hypertension and diabetes. Hypertension in pregnancy patients. So these are the drugs that are used. But in emergency setting, they can even use a magnesium sulfate injection. But usually these are the drugs that they are most commonly used. Hydrolyzing is another drug that they will use to treat during emergency.
All right, thank you very much.
So the next question will be, is atherosclerosis completely reversible by medicine?
Okay, atherosclerosis are not reversed by this group of drugs. Okay, atherosclerosis is a process in the artery that causes the buildup of plaques and are contributing to a cardiovascular disease. So probably the statins probably minimize or reduces the risk of developing atherosclerotic, but not the antihypertensive.
Okay, so our next question. How long does it take for the blood pressure to be stable after taking medication?
Okay, like you see in my slide, I was telling you that if the blood pressure is really high, so you need to at least see some effect with your medication within a month or so. Okay, so you'll be able to see your effect. So, but if the patient is not having such a high medicine or it's just stage 1, so you can actually see the effects or you can see it 3 months later. Okay, but usually you will see it within a month that you can actually see the effect, some sort of control.
So in other words, we must take this medicine continuously until to maintain a proper blood pressure, is that right?
Yes, you need to go at least, if your blood pressure is really high, then you have to go to the doctor for a frequent visit, at least a month. But if it's not that elevated, depending on the stage of hypertension you are, then you probably need to see it every 3 months or 6 months to see how your blood pressure is controlled.
Okay.
All right, so the next question will be, a young person in the young age who is diagnosed for hypertension, can it be cured in a young age without taking medicine?
No, there are patients these are called young hypertensive. Okay, usually people with young hypertension are patients with a family history, a very strong family history of hypertension. So they can develop hypertension. Usually they do not, it does not go away. You probably, depending on what kind of stage you are. If you are having elevated blood pressure, you may need to, you can try the non drug But if the non-drug is not working, you will, despite of your age, you will still have to put, the doctor still have to put you on a medicine, and you still have to take it. It's not something that will go away. So no matter what age you are diagnosed, you will probably have to take the drug for lifelong.
Okay, thank you for the information.
Okay. Next question. Okay. How common is a high blood pressure in younger patients? Is it very rare? Is it very common?
It is not very common, but surprisingly, you see more young patients coming in now with hypertension, with even a heart attack. So it is getting it used to be quite rare, but now it is not so rare as it used to be. So it's common to see sometimes young patients coming in with hypertension. Hypertension can be seen as early as 30 years and after in your early 30s. It's quite common.
Okay. So for our next question.
Is there any condition like this eclampsia women have after delivery?
I am not sure whether they have, but depending on what kind of other comorbidities, if they have other problems, like for example they have diabetes or they have a family history, they might have myocardial. What they call that? Sometimes they have heart problems. Okay, but it is quite rare. But usually they do not come with any conditions after delivery. In majority of cases, unless they have like comorbidities, then you're not sure. They might become, it may be not so favorable outcome for this kind of group of patients.
Okay. So for our next question, for IDH cases, is ACEI and BB can start it directly, or it has to depend on the patient's blood pressure and heart rate readings too?
Okay, for ischemic heart disease, you actually need to start them on both the drugs. Okay, the patient need to be put on both because there are mortality reducing agent in this group of drugs. But of course, these are what we say that you need to do. Okay, but individually, patient come in with a lot of problems. They can come in with other conditions, like for example, they come in with bradycardia. You definitely cannot. If they come in with if they are coming in with other conditions, okay, they have AV, then you can't give them. So you need putting a patient on a drug is looking at the patient as a whole. So you need to see whether they have this contraindication, whether they have the side effect, are they responding to it, and all those stuff before you can actually put it. So that's why probably it's called the art of management.
Okay.
So the next questions will be, could we ask for reducing the strength of the medicine when hypertension is stable?
Yes, definitely. We always treat it based on the patient's response. If the patient is maybe because probably he was not exercising and now he's starting to exercise, probably he may need to reduce his. There are patients that they are, like some of my friends at this age, they are diagnosed as hypertensive. They are taking medicine, they're taking 2 medicines, but they started a good lifestyle. They start hiking and they start jogging. They probably need to maybe reduce the dose, maybe even stop one of the drugs. So yes, we tailor it to their response.
Okay, and I feel that that's the end of our question for today. So once again, I would like to say a big thank you to Dr. Doris for sharing her expertise on the medicine management. It's not every day that we can get advice directly from such a distinguished expert.
Yeah, exactly. We really appreciate your time and support, Dr. Doris. So thank you so much.
Thank you for your time.
All right, thank you very much, Dr. Doris. Hope to see you again soon. So once again, we would like to say what a great way to end the day 2 for our campaign. We're grateful for all of your supports. especially to those who has been tuning in this morning. So I would like to remind our people. Can we show the highlight of our day? Comment section. Okay. So we'd like to remind you that we're going to have our quiz for health talk session, and there are going to be prizes coming soon. So don't go away, and we hope to see you there.
And once again, I'd like to remind everyone to participate in the fitness hashtag challenge. Make sure to subscribe and follow our page in Instagram and Facebook with the username PHC2020QIU.
Okay, so what's in store for tomorrow? How about we're going to have 5 live sessions, including 4 new healthy eating episodes and other health talks, this time by our own QIUP lecturer, Dr. Cairo Anwar.
Yeah, and he's gonna talk about a topic everybody is thinking about, weight management. So see you guys tomorrow.
All right, thank you very much.